Hello everybody, we are going to start the second part of the blood. In my last lecture I was talking about the red blood cells. We'll continue on the red blood cells, then we'll talk about the white blood cells. We'll talk about five different types of white blood cells, how to identify them, the physiological properties of white blood cells, and abnormality in the white blood cells or abnormal white blood cells in the body. Then we'll talk about platelets. Then we'll talk about the blood coagulation or blood clot. And then we'll talk about the blood type or blood group and mismatched blood transfusion. So we were talking about the fate of a red blood cell, how the red blood cells are destroyed and what happens after the destruction of the red blood cells. You must remember that lifespan of a red blood cell is between 90 to 120 days, and after that lifespan the red blood cells get very weak, the cell membranes get fragile, and most of the red blood cells are destroyed in the liver and the spleen. Some red blood cells are also destroyed in the bone marrow. And inside these organs, you have the phagocytic cells, macrophages, I mentioned in last class. So this is a macrophage. And what happens, you see, the old red blood cell is destroyed into many pieces and engulfed by the macrophage. And after the destruction of the red blood cell, the heme and globin part gets separated. You remember the globin part is formed by 4 amino acid chains, 2 alpha and 2 beta, right? So those amino acids get separated. Heme and amino acids of the chains get separated. And the main component of heme in the center, you remember, is the iron. And this iron, I mentioned before, will go back to the bone marrow, okay, to produce new hemoglobin. Also the amino acids, the protein molecules, will go back to the bone marrow to produce new hemoglobin. So these two parts of a hemoglobin will go back to the bone marrow, will be recycled, and the remaining part of heme, except the iron, you remember this is the heme, iron is in the center, this is the iron, this will be recycled. However, the rest part of heme will be converted to biliverdin and then will be converted to bilirubin, the yellow pigment. And the bilirubin will get out through the urine and stool as stercobilin and urobilin, or stercobilinogen and urobilinogen. So let's see here more clearly. This is a nice picture, everything is shown here. Okay, so again you see that the iron goes back to the bone marrow to produce new hemoglobin of new red blood cells, and amino acids will also go back to the bone marrow, right? So these two will go back to the bone marrow to produce the hemoglobin for the new red blood cells. However, the heme will be the rest part of heme will be converted to biliverdin and bilirubin. Now you see here, bilirubin goes to the liver and through the bile duct. This is the bile duct. That takes the bilirubin from the liver to the intestine. This is your intestine, and will get mixed with the food stuff and will get out with the stool or feces. Okay, that's why the stool is yellowish color, because of this bilirubin, right? And small amount of bilirubin will go to the kidney, and through the kidney will get out with the urine. So these are the two ways the bilirubin is excreted or eliminated. Now you see, if for some reason, if any obstruction occurs in the bile duct here, then what will happen? The bilirubin will not be able to go to the intestine, right? Will start to increase in your body, start to build up more bilirubin concentration in the body, because it cannot get out through the stool. So the concentration of bilirubin in your blood will go up, in your body will go up. So the body skin color will get yellowish. You can see from outside the skin, right? As well as the eye. So you see the um, sclera of the eye, which is white. Normally it will get yellowish, and also the skin, nail beds will get yellowish, and that clinical condition is called obstructive jaundice. So if the bilirubin cannot get out, is blocked, then its concentration in your body will go up, and that will cause the yellowish coloration of the skin and the mucous membrane, and that is the jaundice. There are different types of jaundice. Since this is due to the obstruction of the bile duct, this is called the obstructive type jaundice. There is a physiological jaundice that happens in infants. You know that mother's blood remains in the infant's body, and um, the red blood cells that come from the mother's blood will be destroyed, and that is nothing harmful. The infant gets jaundice, but that is called the physiological jaundice or normal jaundice. That's not due to any disease. Okay, so that's the fate of the red blood cell. Now, the disorders of the red blood cells. I mentioned before that if the concentration of, or the number of red blood cell is higher than the normal, that is called polycythemia. Okay, so if the normal average number or count is 5.2 million, this is the average number in 1 microliter of blood, right? So if the concentration or number of red blood cell is more than this, then it will be considered as polycythemia. Now polycythemia could be two types. One is called polycythemia vera. This is a clinical polycythemia. That means it is a disease condition, and it happens usually due to bone marrow cancer or tumor. Okay, so the bone marrow will produce too many red blood cells, more than normal, and that will increase the number in your blood. Okay, and the blood viscosity will increase because the thickness of the blood will increase. Okay, so that is one type of polycythemia. Another is called physiological polycythemia. This one, physiological means normal, right? Polycythemia, this is not abnormal. For example, if you go um, on the top of high mountain in high altitude, where the oxygen level is low, concentration is low, your body will get less oxygen, so your bone marrow will start to produce more red blood cells, so your blood can transport more oxygen. When we'll come back to sea level, again the number will go back to normal. So this is just a physiological response, normal response of your body, right? So this is not harmful. This is a physiological increase of the number of the red blood cell. Another condition that also increases the number of the red blood cell. Sometimes the athletes, they intentionally inject more red blood cells into their blood so they can have better performance. You know that red blood cells transport oxygen, right? So if you inject more red blood cells from outside into your body, the number of red blood cell will increase during the performance. Your blood will be able to transport more oxygen, so you will perform better. But this is not a legal exercise. You cannot do that, but sometimes you will see in the news that the athletes get caught with because of doping. Okay, so that's the increased number of the red blood cells. Now, if the number of red blood cell is less than normal, that is called anemia. That might cause anemia. And the definition of anemia is low oxygen carrying capacity by the blood. And what can cause the low oxygen carrying capacity? If the number of red blood cell count is less, because we know that red blood cells transport or carry oxygen, right? So decreased number of red blood cell will cause anemia. Another condition is decreased amount of hemoglobin. Let me explain. This is a normal person's blood, and these are the red blood cells. Okay, and hemoglobin inside. Normal amount of hemoglobin in each red blood cell. So hemoglobin and red blood cell. So this is normal. Okay, now if you see another blood here, if you take the same amount of blood from another person and you see that the total number of red blood cell is less in same amount of blood, like here you have more red blood cells than here, right? Hemoglobin inside is normal, so definitely this blood, abnormal low red blood cell count blood, will carry less oxygen. So it has less or low oxygen carrying capacity, right? So this is anemic person. That makes sense. Decreased number of red blood cell. This one. Now you see another condition. This is another person. You take the same amount of blood. Here the number of red blood cell count is same, normal, like this one. However, if inside the red blood cell the amount of hemoglobin is less than normal, you see the amount of hemoglobin is less, although the count of red blood cell or number of red blood cell is same. This blood will also carry less oxygen. Makes sense? Decreased because of less hemoglobin. So both are anemic because oxygen binds with the hemoglobin. We know that, right? To form oxyhemoglobin. So in this case, the red blood cell number is same as normal, but this is still anemic because the amount of hemoglobin is less. So less amount of hemoglobin can also cause anemia or low oxygen carrying capacity, right? Another condition is, again you see here, this is another person whose red blood cell number is again same as normal, but the hemoglobin is abnormal. You see the shape of the hemoglobin? This is not normal shape, right? So abnormal. So this abnormal hemoglobin is not capable to bind with oxygen. So it will not be able to transport enough oxygen, right? So this is also anemic. So you see, anemia could be due to decreased or low number of red blood cell, or same number of red blood cell but less amount of hemoglobin inside the red blood cell, and also abnormal hemoglobin inside the red blood cell. So abnormal hemoglobin content anemia. Okay, so these are the main causes of the anemia. Okay, so if you only count the number of the red blood cell and see the number is normal, you cannot say this blood is not anemic, because you have to also see the amount of hemoglobin and the shape and function of the hemoglobin, if it is normal or abnormal. You have to see all these three things to make sure if the person is not anemic. Okay, so different types of anemia, those are the causes of anemia. Now I am going to talk about different types of anemia. One type of anemia is called iron deficiency anemia. You must remember that the heme part of hemoglobin has iron in the center. I mentioned many times. So if the iron in the body is less for some reason, you are not getting enough iron from outside, then this heme will not be able to transport enough oxygen. Make sense? So that is iron deficiency anemia, because iron is an important part of heme. That means hemoglobin. Okay, so that is one reason. In that case, the person will be asked to take more iron-rich food to compensate that loss of or lack of iron. Pernicious anemia is another type of anemia that happens due to deficiency of two things: vitamin B12 and the intrinsic factor. Intrinsic factor. Okay, these two things help to absorb the uh, iron in the intestine. Okay, so if this lack of vitamin B12 and intrinsic factor, they are not enough, then the bone marrow will not produce enough red blood cells. So in that case, the person will have low number of red blood cell related anemia that I explained before. Okay, so that is called the pernicious anemia. Intrinsic factor helps in the absorption of vitamin B12 in the intestine. Okay, so if intrinsic factor is lacking, then vitamin B12 will not be absorbed from the food you eat, and the bone marrow will not be stimulated. So bone marrow stimulation will not occur to produce new red blood cells from the stem cells. Make sense? Sickle cell anemia. This is abnormal hemoglobin content anemia. You remember I mentioned that if you see that the hemoglobin is not normal, this is normal, and if you see inside the red blood cells under the microscope, the hemoglobin in sickle cell anemia, the hemoglobin is like more sickle shaped. Both ends are pointed, and this is like hard, not soft, crystal like hemoglobin, and pointed ends. This hemoglobin is not capable to bind and transport oxygen. Okay, and since the shape of the hemoglobin changes, this is an hereditary disorder. It happens due to an abnormal amino acid. You remember 2 alpha 2 beta chains in the globin part of the hemoglobin. You must remember 4 amino acid chains, right? So in the amino acid chain, if one amino acid, these are the amino acids in the chain, if one amino acid, that is called glutamine, is replaced by an valine, another amino acid, this is called valine. So if that happens, this valine is not good. It will change the shape of the hemoglobin. See, only small change in the amino acid chain will convert the normal hemoglobin to sickle cell hemoglobin, okay, abnormal hemoglobin. And it happens more in African black population. The number of sickle cell patient is more. It is an hereditary disorder, and this is a serious clinical condition. Blood transfusion helps, but it's difficult to keep the patient alive for a long time because these red blood cells cannot transport oxygen. So that's a problem. Okay, and since the hemoglobin gets hard and both ends are pointed, so when the red blood cells try to pass through narrow capillary easily, the pointed ends will break the cell membrane and rupture the uh, red blood cell. Another type of anemia, it's not mentioned here, that happens due to faulty globin chain. This one also is related to faulty globin chain, that is called thalassemia. Okay, faulty protein part, globin. Okay, so this in this case, the hemoglobin, the globin part, the protein part is faulty, and the oxygen will not be able to uh, bind and transported by the hemoglobin in thalassemia. There is another type of anemia that happens due to the depression of the bone marrow. If the bone marrow is depressed, that is called aplastic anemia. You know that bone marrow produces the red blood cells, all blood cells, right? So the bone marrow produces the red blood cells. So if the bone marrow is depressed, then the bone marrow will not be able to produce enough red blood cells, and that type of anemia, decreased number of red blood cell, is called aplastic anemia due to bone marrow depression or loss of bone marrow function. Okay, this can happen due to some drugs, chemicals, especially anti-cancer drugs, chemotherapy, that can cause aplastic anemia. Okay, the site of production is depressed or non-functional. Okay, and another type of anemia, commonly we use that term, and that is called anemia due to blood loss of blood. Of course, if blood loss occurs, then the number of red blood cell will go down in the blood, and that will cause decreased oxygen carrying capacity. Now, blood loss could be two types: acute, that means sudden lot of blood loss, and chronic, slow but for a long time. Acute is sudden and lot of blood loss quickly, and chronic is slow but continuous loss for a long time. Both will cause decreased number of red blood cell because blood is getting out from the body. A good example of acute blood loss is surgery. Major surgery, like big surgery, that will cause a lot of blood loss. Accident, right? And chronic, good example could be like ulcer in your stomach, and from that ulcer, small amount of blood will leak all the time. Okay, so eventually it will cause anemia. Another is worm in the intestine, hookworm, tapeworm. Those are different types of worm, can reside in the intestine, in your gut for a long time, years after years, and they suck a lot of blood. So those are the causes and types of anemia. So this part is very important, and you have to understand um, and memorize for your exam. There will be few questions from here. Okay, causes and types of anemia. Here you see sickle cell anemia. You see the red blood cells get elongated because the hemoglobin inside it gets elongated and pointed. Okay, so the shape of the red blood cell also changes. This is a good one, you see. So these red blood cells cannot transport oxygen. So if the number is really high, then the blood carrying capacity, oxygen carrying capacity is significantly low. Now, what are the symptoms of anemia? Symptoms. There are a few common symptoms of anemia. One is from outside. If you see paleness in the skin, okay, that is an indication, and also the nail beds, where you can easily see the blood flow. So if you see paleness, the color changes. So that is a good indication of anemia. Shortness of breathing, okay, of course, because the person's blood cannot carry enough oxygen, so the person will easily get tired. So that is called fatigue. Okay, fatigueness or tiredness. And yeah, so those are some common symptoms of anemia. Okay, now we'll talk about the white blood cells. Okay, first we'll see the types of white blood cells. Let's talk about the types. We know that there are 5 different types of white blood cells, and we divide them into 2 groups. Okay, neutrophils, eosinophils, basophils. These 3 belong to granulocytes. Why? Because if you see these 3 in the cytoplasm, you will find granules, tiny dot like structures, chemical granules. And they end with fils because these granules can be stained with color, philia, liking of dye or color. And other 2, lymphocytes and monocytes, these end with cytes. They don't have granules, that's why they are called. A means absence, granulocytes. Okay, so no granules, so they cannot be stained or colored by dye. So these are 5 different types of white blood cells. I mentioned before that most of the white blood cells are neutrophils, about 67%. If you count 100 white blood cells, you will find about 67 of them are neutrophils. Eosinophils about 25%. Then these are less than 4%, each of these. Now let's see the pictures. So these are the red blood cells and these are the white blood cells. White blood cells have nucleus, right? So you see the blue color, dark blue colored structure is the nucleus. Okay. However, in the cytoplasm, outside of the nucleus, you see color. So this one, if you look carefully, in the nucleus, you see lobes. This one has 3 lobes in the single nucleus, but nucleus is lobulated like this. You see, this is the neutrophil and the nucleus has multiple lobes. It could be 3, 4, 5 or even 6. This one has 4 lobes, right? So if you see the nucleus has multiple lobes and the cytoplasm here, you see, is not deeply stained. Why? Because the granules here take both acidic and basic stains, so they neutralize each other. So granules take both acidic and basic stains. So that's why the color is not clear, so cytoplasm is pale, but nucleus is multi-lobed. So if you see these two things, this is a neutrophil. Okay, so this is a neutrophil. You see multiple lobes and pale cytoplasm. This is also a neutrophil. Now if you see an eosinophil, this is an eosinophil. What you will see, eosinophils are usually, the nucleus is bilobed. If you see here carefully, this is one lobe, this is another, two lobes. So bi, not multi. And this is very important. The granules are stained with acidic dye called eosin, and that dye is red or orange. So if you see red or orange color in the cytoplasm, here you can see red or orange. So that is eosinophil. Okay, basophil, also the nucleus is usually bilobed like the eosinophils. So by looking at the nucleus you cannot tell, because both eosinophil and basophil are bilobed, but in case of basophil the granules are stained with basic dye, that means blue or purple colored dye, not red or orange, so blue or purple. Okay, and the nucleus is bi. So that's how you will separate the eosinophil and basophil, by looking at the color of the granules in the cytoplasm. Okay, now monocyte, first, monocyte is much bigger in size than the other four types of white blood cells, and the nucleus is kidney shaped or bean shaped nucleus. So this is how you can identify monocyte, and since it is cyte, no granules, right, no stain, so this is a monocyte. You can see here, bigger and kidney shaped or horseshoe shaped nucleus. Okay, and lymphocyte, another site, is easy to identify. This is the lymphocyte, and if you see the nucleus, it is large round nucleus, occupies almost the whole cell. Only thin rim of cytoplasm is around the nucleus. So this is the nucleus, round large nucleus, and thin rim of cytoplasm around the nucleus. So these are 5 different types of white blood cells, and these 3 fields are granulocytes, and these 2 sites are agranulocytes. Okay, and this is very important, how you count different, identify and count different types of white blood cells. Counting different types of white blood cells is called differential count, DC, or differential count. You identify the white blood cells and how many each type, that is differential count. Total count is TC, or total count. Okay, now let's go back to this slide. Properties of the white blood cells. These are called the physiological properties or functional properties. Margination, diapedesis, amoeboid motion, positive chemotaxis, and phagocytosis. Let me quickly explain these physiological properties of the white blood cells. If I ask you what are the properties of white blood cells, you have to mention all these. Don't say that there is a nucleus or there are granules. Those are not the properties. These are the functional properties. Okay, so what is margination? This is a vein, or for example a blood vessel, and this is outside tissue. If infection occurs here, site of inflammation or site of infection. Okay, so you have, for example, bacteria or viruses here caused inflammation. Okay, so when the white blood cells will pass through the nearby blood vessels, in the wall of the blood vessel you have narrow tiny pores or holes. So these white blood cells can detect that around them there is a site of inflammation. So what they will do, they will just, instead of passing through the blood vessels, they will get attached to the inner surface of the wall like this. This is called margination. Okay, and then what they will do next, they will try to get out through these narrow holes or pores. So they will push out their part through the narrow pore and eventually they will get out. And squeezing through these narrow holes is called diapedesis. Okay, so by diapedesis they come out, squeeze out through the pores. And then, when inflammation occurs in the tissue, in this area, the tissue secretes some chemicals, and these chemicals attract the white blood cells towards the site of inflammation, and this is called positive chemotaxis, chemical attraction. So by that positive chemotaxis, the white blood cells will move towards the site of inflammation. In some cases in your body, the chemicals will repel, tell the other cells don't come here. Okay, so that is called negative chemotaxis, will repel the cell to save them. In this case, white blood cells will be attracted, that's why positive chemotaxis, chemical attraction. And after the white blood cells arrive here, they will destroy these pathogens, antigens, okay, by phagocytosis or other means. And phagocytosis is engulfing, that eating. So phagocytosis is the last step, right? So all these are the properties of the white blood cells. So must remember and know how to explain them. I mentioned before that the count of white blood cell is here, it says 5 to 11, but most of the places you'll see 4 to 11 thousands per microliter. Okay, so if you see this is the actual range of the white blood cells, thousands per microliter, 4 to 11. And another name of white blood cell is leukocyte. So leukocytes, right? Leuko means white, cytes means cell, white colored cells. Now, if the number of white blood cell goes above the upper limit, above 11,000, that is called leukocytosis. If the number is slightly higher than the normal, okay, increased number of white blood cell is leukocytosis. Now, what can cause leukocytosis? very often you can get leukocytosis by general infection. If any infection occurs inside the body, white blood cells will be produced more to destroy the pathogens or antigens. Okay, so this is a good thing. Your body responds by producing more white blood cells, so the number of count will be more. And sometimes it's difficult to know if you have any internal infection inside the body. So if you do count the white blood cell, the number, if you see it is slightly higher, that is one indicator that somewhere inside the body you have infection, and that's why the number of white blood cell is slightly higher, and which is normal. Okay, and but a serious clinical condition or abnormal condition of white blood cells is called leukemia. You probably heard about this. This is also commonly known as blood cancer, right? In this case, the number gets extremely high, uncontrolled production. Okay, this is slightly higher, but this is unusually uncontrolled production of white blood cells. So what happens in leukemia, the number of white blood cell in the blood increases a lot, and that huge number of white blood cells in the blood will increase the viscosity, makes sense, thickness. So the blood will be very thick, and when this blood will try to pass through narrow uh, capillaries, the capillaries will be ruptured because of the thickness of the blood. And that's why in leukemia we see uh, multiple bleeding, internal bleeding due to rupture of the narrow blood vessels due to thickness of increased viscosity of the blood. That is one thing we see, internal bleeding. And another is, although the number of white blood cell increases a lot, however, most of these white blood cells are non-functional. So although you have huge number of white blood cells, they cannot fight against the microorganisms. Okay, uh, immature white blood cells, and that's why your body often gets multiple infections. Makes sense, right? Your body cannot destroy the antigens, so uh, multiple infections. These are two things we see in leukemia. Of course other things happen, but just remember these two, and you understand why, right? Due to increased viscosity, bleeding or rupture of the blood vessels, and due to abnormal white blood cells, they cannot fight against the microorganisms, so you get multiple infections. Okay, so here you go over neutrophil, eosinophil, basophil. You see blue granules, red or orange granules, right? And multiple lobes here. You just go over the functions of uh, these different types of white blood cells. Remember, all white blood cells are responsible for uh, immunity or defensive function of the body. They destroy the antigens or pathogens, microorganisms. Here, monocyte and lymphocyte. Now, just remember one thing here, that basophils releases two important chemicals, histamine okay, and heparin. Remember these two chemicals. Histamine causes inflammation, and heparin prevents blood clot. It is a natural anticoagulant. Okay, so these two chemicals are produced by the basophils. Okay, eosinophils modulate allergic reactions in the body. So if any allergy or allergic reaction takes place in the body, you will see the count of eosinophil changes. By changing its number, it modulates the allergic reaction. So just remember, these are a couple of important things that you will be asked. Okay. Another information here about the monocytes. Monocytes are the largest in size, right? And kidney shaped or bean shaped nucleus. Monocytes can get out from the blood and enter into the tissue and can be converted to macro tissue macrophage. Okay, so in the tissue you have macrophages, the phagocytic cells. They actually are formed from the monocytes. Okay, here you see enter into the tissue and become macrophages. Okay, hemostasis. Hemostasis is the stoppage of bleeding or haltage of bleeding or arrest of bleeding. Arrest or stoppage or haltage of bleeding. Okay, what happens, when you get a cut, initially bleeding starts, then after a while the bleeding stops by clot formation, right? So that is hemostasis. First, three things happen in hemostasis. These are the three phases of hemostasis. Three things will stop the bleeding. So let me explain. This is a blood vessel. Okay, you got a cut here. Okay, so now I am showing the blood vessel here. You got a cut here, right? So the blood vessel will look like this, right? So first thing what happens, you see the lumen here. If I just see this lumen here, making it larger, in the wall of the blood vessel you have the smooth muscle, right? So this is smooth muscle in the wall, and the smooth muscle will contract because of the pain from the nerve due to the rupture, right? So due to the cut, the nerve will cause pain, and that pain reflex will contract the smooth muscle in the wall of the blood vessel. So what will happen when contraction of the smooth muscle will occur? You see the lumen will get narrow, squeeze due to contraction, right? Makes sense? So it will get smaller. Instead of like this big, it will constrict. So that will decrease the bleeding, right? First thing, narrowing of the lumen due to the contraction of the smooth muscle. That is called the vascular spasm. Let me write it here. Vascular. Here it said vascular phase, vascular spasm or constriction of the lumen. Okay, so that will reduce the bleeding. Then what will happen next? The platelets. Platelets love to get attached to the rough surface. You remember I mentioned before in the first part, the surface of the platelet gets sticky when it gets attached to a rough surface, okay? Because platelets secrete two couple of chemicals that makes the surface sticky. One is called thromboxane, A2, ADP. These chemicals make the surface of the platelets sticky. So when many platelets will get sticky, the surface, they will get attached to each other and will form a plug like this, right? So the platelet plug will be formed here to block the opening. Okay, so platelet plug formation. Okay, so that is the phase 2. And then what will happen, you know, not only platelet but a plasma protein. I mentioned two things cause formation of clot or coagulation. One is the platelet and another is the fibrinogen, the plasma protein, you must remember from part 1. So what happens next, you see, uh, so this is the platelet plug here now, right? And blood coagulation will form a fibrin mesh, network of fibrin that will cover that whole thing, clot or platelet plug. How the fibrin mesh is formed? Fibrin mesh is formed by coagulation. Coagulation converts the fibrinogen, you must remember this is a plasma protein, so to fibrin threads, and many fibrin threads will be formed and they will get attached to each other to form the mesh. So fibrinogen will first form the threads, and fibrin threads will get attached to each other to form the mesh, and this mesh will cover the whole clot. So coagulation is the last step in which the fibrinogen plasma protein is converted to threads, and threads will form network or mesh, okay, to stabilize the clot. So these are the 3 phases of hemostasis. So I have explained this, you see here. Okay, so ADP, thromboxane A2 I mentioned, and also PDGF, another chemical is secreted from the granules of the platelets, platelet derived growth factors. Here you see these are the platelets. Okay, so just go over fibrin thread, fibrin network or mesh. Here you see fibrin mesh. You see here the fibrin threads and they get attached to each other to form the mesh. Okay. Now the coagulation can occur in 2 pathways. One is called the extrinsic and another is the intrinsic pathway. Let me explain the differences between the extrinsic and intrinsic pathways. This is a blood vessel, and if you get an injury in the blood vessel or in the tissue, that will cause the rupture of the blood vessel, right? And the surface will get rough and the platelets will get attached to form the plug, right? So that is one way that I explained the clot is formed. So this is extrinsic pathway because the wall of the blood vessel gets ruptured, and that wall will release the tissue factor, because from the tissue uh, chemicals will be released, okay, and that will stimulate or initiate the extrinsic pathway, okay, or trigger the extrinsic pathway. When the tissue will be ruptured, the wall of the blood vessel or outside tissue will be ruptured. That we get when we get a cut normally, right, or injury from outside. So that is extrinsic. Now you all know that without any injury uh, from outside, sometimes clot is formed inside the blood vessels, right? That's a problem, big problem. Like coronary artery is blocked by that clot, although there is no rupture from outside or injury from outside. So uh, you remember the platelets love the rough surface, and when you get older, especially, the wall of the inner surface of the wall of the blood vessel might get rough, okay, and platelets love the rough surface, so platelets can get attached to the wall and form a clot without any injury from outside, right? So that will be initiated by the platelet. When the platelet will get attached to the rough surface, will secrete the chemicals that will make the surface sticky, and a plug is formed. So this is intrinsic. Now makes sense, right? So platelets factors will um, initiate the intrinsic pathway, not the tissue factors. Okay, so tissue factors trigger or initiate the extrinsic pathway of coagulation, and platelet factors will initiate or trigger the intrinsic pathway. And the final outcome of both pathway is same. They go through different reactions, two separate pathways, so two separate sets of reactions, but finally they will produce the same chemical that is called prothrombin. You need to remember this name. Although they are triggered differently, they go through different pathways, different series of reactions, but finally they will both pathways will produce prothrombin activator. Okay, so this is the chemical. Now from its name you can tell it is called prothrombin activator. That means it will do what? It will activate the prothrombin. That means prothrombin is not activated, right? Prothrombin is inactive, and this prothrombin activator will convert the prothrombin, inactive prothrombin, to active thrombin. Makes sense? That's the function of activator. Will activate the prothrombin and convert it to thrombin. So this is active. Okay, now the active thrombin will do what? You remember in last slide I showed you the plasma protein fibrinogen will be converted to fibrin thread, and will form mesh. So that is coagulation, right? So prothrombin activator will be produced by both extrinsic and intrinsic pathways, although the pathways are different. Then this part is same for both, right? So finally we'll get the fibrin mesh, this mesh. Okay, clot retraction. After the clot is formed, then the after 30 to 60 minutes, uh, the water part inside it or fluid part comes out. Retraction, that means the clot will squeeze, will reduce its size. Inside the clot you have what? You have the platelets, right? Platelet plug. So inside the platelets you have actin myosin. You must remember from NP1, actin myosin in the muscle fibers. They help in contraction. So inside the platelets you also have actin myosin, and they will cause the contraction of these platelets. So when inside the clot the platelets will contract, the liquid part will come out, that is called the serum. So the release of serum occurs due to the retraction of the clot or squeezing of the clot, reducing the size, and the water part that comes out is the serum. Okay, and it continues for 30 to 60 minutes. Okay, so clot is actually a semi-solid um, jelly-like structure. Okay, clotting disorders. That if the lack of clotting factors in your blood, that might cause slow clot formation. For example, in your blood you must remember you have two pathways, extrinsic and intrinsic, and a series of reactions, right? And you have 13 different clot factors. We name them using Roman numbers 1, 2, 3, 4. First four are called the essential factors. Essential, okay? Because without lack of or absence of any of these first four factors will not cause clot formation, will not cause coagulation. That's why they are called essential factors. Then from 5 to 13, these are non-essential. 5 to 13. However, lack of one or more of these non-essential will slow down the clot or delay the clot formation. Although clot will be formed but will be delayed. But lack of 1 to 4, any of these will not cause the clot. So if you have lack of clot factors in your blood, that will cause abnormal bleeding. Make sense? And that happens. Delayed clot formation will increase or prolong the bleeding. So that is one condition. Another clotting disorder is called thrombus formation. You remember I mentioned that intrinsic pathway can produce a clot inside the blood vessel, right? And if a clot is formed and is attached to the wall of the blood vessel, it's fixed there, this is called thrombus. Dangerous, right? Can block the artery, and if it blocks an artery in the brain or the heart, that can cause even death. However, sometimes, this is interesting, this clot, due to the flow of the blood, can get detached from the wall and start to move freely in the blood, right? This is even more dangerous because it can be produced in your leg, in the artery or vein in the leg, and go to the lung or heart or brain and stuck there. So this is very dangerous, right? This is called embolus. free floating clot. This is fixed thrombus, and free floating one is the embolus. So these are some clot disorders. There are more, just remember these few. Okay, the last thing is the blood type. The blood type is determined by the presence or absence of the antigens on the surface of the red blood cells. So these are the red blood cells. Okay, and on the surface of the red blood cells you have different antigens. I am showing by different shapes. Okay, that will help you to understand. So these are the antigens called agglutinogens. Okay, what type of antigen is present on the surface, that determines the blood type. So on the red blood cell surface, so if this is A, for example, this is A antigen, this is B antigen, and this is D antigen. Okay, these are the main antigens. There are more than 3, but most of those are weak. So blood type is only determined by looking at these 3, presence or absence. If on the surface of your red blood cells you have A antigen, your blood type is A. If you have B antigen only, your blood type is B. If you have both A and B, your blood type is AB. Now D determines positive or negative. If D is present, D antigen, your blood type is positive. So here on these persons, for example, person A, let's say person X, will be easy. Okay, person X, on his red blood cell surface you have all 3 types of antigens, both A, B as well as D. That means his blood type is what? AB positive. Makes sense? AB positive. Because of D it is positive. Okay, now this is person Y. On his red blood cell surface you have only this one, no others, no B, no D. So his blood type will be what? This is A antigen, so only A, so blood type is A. No B, so it's not B. No D, so negative, A negative. Makes sense? Now you see here, this is another person, person S. He has A and D, but not B. Now tell me, what is his blood type? This is A and this is D. Because of A, his blood type is A, and because of D, it is positive. So A positive. Makes sense? Now another person's red blood cell surface, you have no A, no B, no D. No, nothing. None of those. So he will be O. And since D is also absent, O negative. Now if I add a D only here, no A, no B, but I see D antigen, so O positive. Makes sense? Now if I add A and B, A, B and D, that means AB positive, that I mentioned here, right? So this is how the blood type is determined. Okay, D is also called RH because first it was identified in rhesus monkey, so RH came from the rhesus monkey. Okay, so now just remember mismatched blood transfusion, why that is a problem. When we do blood transfusion, you must remember 2 things. We consider two things. Okay, we consider the antigens of the donor and antibodies of the recipient. Okay, so you see here there is a rule that is called, if on the surface of the red blood cell any antigen is present, same type of antibody must be absent in the plasma. This is the red blood cell and this is the plasma. Okay, now you see on the surface of this person's red blood cell you have A antigen, right? So in the plasma the rule is same type of antibody must be absent. So A antibody must be absent, otherwise they will react, right? A antigen, A antibody, they will react, they will uh, bind with each other and destroy the red blood cell. So which type of antibody can be present? The opposite type, B antibody. If on the surface of the red blood cell you have A antigen, in the plasma you have B antibody. Now you tell me, if this is another person, on his red blood cell surface you have B antigen, that means his blood type is B, right? Antigen. In the plasma, which antibody will be present? The opposite one, not the same one, A antibody. Make sense? Now during blood transfusion we consider the antigens of the donor. So for example, if this person is the donor, this person is the recipient, this is type A blood, right? Donor's blood type is A because on the surface you have A, and recipient's blood type is B because on the surface you have B. Okay, and when this person donor will give blood to this person, the rule is we will see the antigen of the donor. So we'll see the antigen of the donor. So donor's antigen is A, right? And we'll see the antibodies in the recipient. This recipient's antibody is A. So when this blood will enter into the recipient's body, you see on the red blood cell surface you have A antigen. In the plasma of the recipient you have huge amount of A antibody, right? So when the blood will enter, immediately these antibodies will bind with these antigens and will destroy the red blood cell. Okay, same thing will happen if this is donor and this is the recipient. This B person gives blood to A, then now let's consider this donor's antigen on the red blood cell surface is B, and in this plasma you have B antibody. So when this blood will enter, this antibody will bind with this antigen and will destroy the red blood cell. That's why we cannot give another type of blood to the recipient. We have to give either same type. Most safe is giving the same type. Okay, that's why we do cross matching. So the antibody and antigens on the surface of the red blood cell. Okay, so these are the antigens, these are the antibodies. And when mismatched blood transfusion will occur, the donor's blood will be destroyed due to antigen, same type of antigen antibody reaction, and that may cause the complications of mismatched blood transfusion. Okay, so the last thing is, so you have to draw and practice to understand that I showed you. If you keep just practicing, you will it will make it clear to you. Okay, the last thing, a clinical condition that is called erythroblastosis fetalis. If the mother is Rh negative, that means mother's blood type is negative, and the infant or child is Rh positive, then what happens, from the infant's body, the positive blood will enter into the mother's body. You know that if it is positive, infant is positive, this is infant, then on the surface you have D antigen, right? Remember that D makes positive, so infant's red blood cell surface has D antigen, and mother is negative, so mother's red blood cell surface doesn't have D because it is negative, mother is negative. So when uh, this D antigen from the fetus will enter into the mother's body, you all know when an antigen enters into your body in response to that, your body produces antibody. For example, when you know coronavirus enters into your body produces antibody in response to that, right? So when infant's blood will take the D antigen into the mother's body in response to this D antigen, it is coming from outside, that means infant's body, mother's body will respond and produce huge amount of D antibody. Make sense? Antibody will be produced, and that antibody will enter into the fetus from the mother. Okay, in first child, the child will usually not suffer from erythroblastosis fetalis, because the to develop huge amount of antibody in the mother's body, it takes some time. So first time, mother's body will not be able to produce huge amount of antibody, but again, second time, if same mother gets pregnant with positive infant or child, then again D antigen will enter into the mother's body, and this time mother's body will produce quickly a huge amount of antibody, and that will go back to the infant, and D antibody will bind with D antigen on the infant's red blood cell surface and will destroy the red blood cells of the infant, right? So huge number of infant's red blood cells or child's red blood cells will be destroyed by the same type of antibody coming from the mother's blood, and that is called the erythroblastosis fetalis. When the red blood cells will be destroyed in the fetus blood or body, bone marrow will produce new red blood cells, and most of those red blood cells are immature. Erythroblasts, blasts are immature. So immature red blood cells will try to replace the destroyed mature red blood cells. So in the blood circulation, you'll see a lot of immature red blood cells, and immature red blood cells, you already know, have nucleus, no hemoglobin, so they are not useful to transport the oxygen, right? So infants may not survive because of the immature red blood cells, erythroblasts, in the fetus blood. That's why it is called erythroblastosis fetalis. In the fetus blood, erythroblasts are found. That means immature nucleated red blood cells are present. They don't have hemoglobin yet. Okay, so that's all about the blood. So let's stop here, everybody.